Hi everybody and welcome to our module on COPD treatment. Let's talk about the treatment of COPD. First of all, smoking cessation is essential for patients with COPD. It does not cure the disease, but it slows the rate of decline in FEV1 and therefore it prolongs survival. If you look at this graph at the bottom of the screen, it shows FEV1 along the y-axis and the age of the patient along the x-axis. Even among non-smokers, FEV1 declines as you age, but among smokers it declines much more rapidly, and this can lead to symptoms of COPD. If a smoker becomes an ex-smoker, FEV1 continues to decline but at a slower rate, and therefore smoking cessation prolongs survival among patients with COPD. And this brings me to a very high yield point to note for your boards. Only 2 interventions have ever been shown to decrease mortality among patients with COPD, and those 2 interventions are smoking cessation and oxygen supplementation, which we'll talk about later. There are lots and lots of drugs used to treat COPD that we'll talk about in this video. All of them improve symptoms, but none of them have been shown to decrease mortality. So that's a nice segue into some of the drugs used to treat COPD. The 2 main classes of drugs are bronchodilators and corticosteroids. This is very similar to the treatment for asthma, although the drugs that are used are different and the way they are used is different as well. In terms of bronchodilators, there are 2 forms of drugs that work this way. There are the beta agonists and the muscarinic antagonists. There are short-acting beta agonists, sometimes called SABAs. The main drug in this class is albuterol. And then there are long-acting beta agonists, sometimes called LABAs. Drugs in this class are drugs like salmeterol and formoterol. In terms of muscarinic antagonists, there are also short and long-acting drugs. The short-acting ones are called SAMAs. The main drug in this class is ipratropium. And then the major long-acting muscarinic antagonist used in COPD is tiotropium, also called LAMA. In terms of corticosteroids, some patients take inhaled corticosteroids. You can also prescribe oral and intravenous corticosteroids. These are especially used in patients having exacerbations of their disease. As you may know, corticosteroids have lots of side effects from long-term use, things like osteoporosis and cataracts, lipid abnormalities, adrenal suppression, but all these things only occur in patients taking oral corticosteroids for long periods of time, like months or years. When patients take inhaled corticosteroids, these effects generally do not occur because very little of the drug is absorbed. The main side effects of inhaled corticosteroids are oral candidiasis and dysphonia. So dysphonia means the voice can change, and oral candidiasis is the growth of the fungus candida. This is an example of it shown here. Patients who take inhaled corticosteroids can have some of the drug absorbed on their tongue and their buccal mucosa. That leads to immunosuppression inside the mouth, and that can allow the fungus candida to grow. Let's talk about theophylline. So theophylline is a bronchodilator. It's an oral drug that has multiple complex mechanisms that are incompletely understood. Theophylline has a lot of toxicity and it has a narrow therapeutic index, so you have to administer this drug and then check the levels and titrate the dose to get the appropriate levels. And the goal is a peak serum concentration of 10 to 20 milligrams per liter. Theophylline is a very old drug. It has lots of side effects, so it's not used much in the modern era except in cases of severe refractory COPD. The thing you always want to remember about theophylline is that it's metabolized by the liver P450 enzymes, and therefore it has many drug-drug interactions. Some of the common culprits I've listed on the slide here, any of these drugs can potentially boost the level of theophylline, and that can cause theophylline toxicity. In addition, the herbal supplement St. John's wort is also well known as a substance that can interact with theophylline. Clinically, the main areas affected by theophylline when the drug level becomes toxic are the GI tract and the brain. In the GI tract, it often leads to nausea and vomiting, and in the brain, it often leads to seizures. A patient who is on this drug who develops nausea, vomiting, and seizures is probably a patient with toxic levels of theophylline. Theophylline also has cardiotoxicity. It blocks adenosine receptors, and what adenosine does in the heart is slows the heart rate. So when you block these receptors, you increase the heart rate. If you look on the right side of the screen, this is the structure of theophylline. This chemical structure is called a methylxanthine. And it's very similar to the base adenine, which is found in adenosine. It's also similar to caffeine. So because it's similar to adenosine, that's why it can block adenosine receptors. So when you block those receptors, the heart rate will go up. And this can lead to arrhythmias. Patients can sometimes develop atrial tachycardia and atrial flutter. And this is the way that people die in cases of overdose or severe poisoning with theophylline. Another thing to know is that a patient who is on theophylline for asthma or COPD and develops a supraventricular tachycardia, for those patients, we often administer adenosine to try and slow the heart rate, but it won't work in patients on theophylline. This really doesn't happen much anymore, but historically, when theophylline was much more widely used, patients on this drug would come in with tachycardias, and doctors would administer adenosine, which is a standard thing to do for patients with supraventricular tachycardias, and it wouldn't work. And that's because theophylline blocks those adenosine receptors. And then our final COPD drug that we'll discuss is roflumilast. This is an oral medication for COPD. It works by inhibiting the enzyme phosphodiesterase 4, and when this enzyme is inhibited, cellular levels of cyclic AMP rise. This causes a decrease in the activity of inflammatory cells, and it also can relax the airway smooth muscle. This is really a drug sort of last resort. It's only used in patients who have severe refractory COPD. So now that we understand all the different types of drugs used in the treatment of COPD, let's talk about how you select drugs for a specific patient. And in order to do that, you need to understand that we treat COPD differently depending on whether the patient is having an acute exacerbation or whether the patient needs chronic therapy for their condition. So patients having acute exacerbations of COPD present with increasing cough, sputum production, or dyspnea, and these are often triggered by viral or bacterial pulmonary infections. It's a clinical diagnosis. There's no specific test. A patient with a history of COPD who presents with these types of symptoms is considered to be having a COPD exacerbation. Patients with COPD exacerbations are often treated in the emergency room and in the hospital. The first thing to do is to administer oxygen. You titrate it to achieve an oxygen saturation of 88 to 92%. We generally don't aim for higher oxygen saturations, and the reason is because potentially that can suppress the respiratory drive. Nebulized therapy is often administered. The classic therapy is Combivent. It's albuterol with ipratropium mixed together so that they're getting both a beta agonist and a muscarinic antagonist. Once you get the patient stabilized with oxygen and nebulizers, you usually start steroids. Usually either IV or oral steroids are used. There are many potential regimens, but some of the common regimens are prednisone 60 milligrams daily. This is an oral therapy, or methylprednisolone 80 milligrams IV every 8 hours. This is an IV therapy for patients coming into the hospital. And then finally, in COPD, antibiotics are always administered to patients with severe exacerbations who are being hospitalized. This is in contrast to asthma. In patients with asthma exacerbations, we do not give antibiotics unless there is specific evidence of an infection. That's not the case in COPD. Clinical trials have shown that antibiotics are effective in improving outcomes in all patients, provided that they're having a severe exacerbation that requires hospitalization. So once you do all those things on the last slide, like give oxygen and give nebulizer treatments, some patients with COPD will still have respiratory distress. Those patients need a higher level of respiratory support. One option is to intubate the patient and place the patient on mechanical ventilation. But before you do that, what you should try, and I want you to know this for your boards, is non-invasive ventilation. This is positive pressure ventilation, but it's not administered through an endotracheal tube. If you look at this woman on the screen here, she is hooked up to a mechanical ventilator, just like a patient who's intubated, but she does not have a tube down her throat. Instead, she has a mask on which forms a seal and provides positive pressure into her lungs to increase oxygen uptake. This is called non-invasive ventilation, and it's used in acute respiratory failure, and in many cases, this avoids intubation because the patient can use the non-invasive ventilation for a few hours until their disease severity subsides. You can only do this in patients who are awake, alert, and cooperative, but on board exams, always consider this as an option before you choose to intubate the patient if the patient is a candidate for non-invasive ventilation. As I mentioned earlier, antibiotics are given to all patients with COPD exacerbations that are severe and require hospitalizations. Now, studies have shown that viruses cause up to 50% of exacerbations, but the other 50% can be caused by bacteria. And some of the common bacteria are Strep pneumoniae, H. flu, and Moraxella. And so because clinical trials have shown antibiotics are effective in all patients who require hospitalization, that's generally what we do. The antibiotics that are commonly used include the ones I've shown on the screen: fluoroquinolones, especially levofloxacin, macrolides, especially azithromycin, and in some cases amoxicillin clavulanic acid is given. So back to this slide, now we've talked about how to treat acute exacerbations of COPD. This kind of treatment is often administered in the emergency room or in the hospital. I'm going to switch gears now and talk about chronic long-term therapy for COPD. This is often administered as an outpatient, and the idea here is to try and modify symptoms. According to the most recent guidelines, the way you select chronic therapy for COPD is based on an assessment of the patient's symptoms plus the number of exacerbations per year. In terms of symptoms, patients are assigned a grade from 0 to 4. Grade 0 patients have breathlessness with strenuous exercise only. These are the patients with the mildest symptoms. At the other end of the scale, grade 4 patients are too breathless to leave the house, and they have breathlessness with minimal activities like dressing. And then grade 1, 2, and 3 patients are in the middle. So using this scale, you assign patients a grade from 0 to 4. That's the first step in determining chronic therapy. So once you've decided on the severity of a patient's symptoms, you can choose COPD chronic therapy based on a combination of the patient's symptoms and the number of exacerbations they experience per year. Grade A patients have mild symptoms, a 0 or 1 on the scale we saw in the last slide, and they have 0 or 1 exacerbations per year. For these patients, the only therapy that's recommended is a short-acting beta agonist or short-acting muscarinic antagonist as needed, meaning PRN. Grade B patients have more severe symptoms. They are a 2 or greater on the scale on the last slide, but they still have only 0 or 1 exacerbations per year. These patients get the same therapy as grade A patients, a SABA or a SAMA as needed, but they can also be administered a long-acting beta agonist or a long-acting muscarinic antagonist. Grade C patients have mild symptoms, a 0 or 1 like we talked about in the last slide, but they have more exacerbations, 2 or more per year. These patients are complex and require more therapy. They get a SABA or SAMA as needed, just like everyone does, but they can also be prescribed other drugs, and there are a bunch of choices. They can be given a long-acting muscarinic antagonist, or a LABA plus an inhaled corticosteroid, or they can be given both a long-acting beta agonist and a long-acting muscarinic antagonist. And then finally, grade D patients are the sickest patients. They are at the highest risk of adverse outcomes. They have moderate to severe symptoms, meaning a score of 2 or more on the symptom scale, and they have 2 or more exacerbations per year. And these patients can be given all the drugs used for grade C patients plus other drugs. If you look at the bottom of the screen, sometimes these patients are given theophylline or roflumilast like we talked about a few slides ago. So this is the most recent guidelines, and this is how you choose chronic therapy for COPD. And just one aside here, in COPD, inhaled corticosteroids are never given alone, and this is in contrast to asthma, where sometimes they are given alone. There have been clinical studies showing that inhaled corticosteroids alone lead to worse outcomes compared to inhaled corticosteroids combined with a bronchodilator. So in terms of your board questions, you never want to choose an inhaled corticosteroid alone as chronic therapy for COPD. I just want to pause and make a quick aside here. In the video on COPD diagnosis, I talk about disease severity and how that is determined by the patient's FEV1. Now, while it's true that the severity of disease is determined by FEV1, that is not what dictates treatment. Treatment is dictated by symptoms and number of exacerbations per year. Make sure you understand that for your board exams. If they're asking you how severe the patient's disease is, you want to answer FEV1. If they're asking you what determines the treatment for the patient, you want to answer symptoms and number of exacerbations per year. Some other interventions are shown on this slide. As I mentioned earlier, chronic oxygen therapy is one of very few interventions for COPD that are associated with increased survival. They're used only in patients who have hypoxemia, and this generally means oxygen is only indicated if a blood gas shows a PaO2 less than 55 or the room air oxygen saturation is less than 88%. Pulmonary rehabilitation is a structured exercise program. It can improve exercise capacity and quality of life and decrease dyspnea, and this is a mainstay of treating COPD. It's not been shown to improve survival, but it does improve quality of life and symptoms. Vaccinations, especially for influenza and pneumonia, are essential in COPD. And then also, as I mentioned earlier, smoking cessation is associated with improved survival, just like chronic oxygen therapy. For patients with advanced end-stage COPD, there are a couple of surgical options. The first one is called lung volume reduction surgery. It's also called a bulectomy. In this operation, diseased lung tissue is removed, and this allows the healthy lung tissue to expand, and therefore that improves ventilation. And then finally, lung transplantation is an option for some patients. I'll finish with this slide and mention a cardiac arrhythmia that's common among COPD patients called multifocal atrial tachycardia. Multifocal atrial tachycardia is a rapid heart rhythm, that's why it's called a tachycardia, and it's an irregular rhythm with multiple P-wave morphologies. If you look at the bottom of the screen, this is an EKG tracing showing multifocal atrial tachycardia. First of all, notice that the QRS complexes are close together, so it's a tachycardic rhythm. And then also note that there's lots of different P-wave morphologies. This one has a different shape from this one here, which has a different shape from this one here. And anytime you see a tachycardic rhythm with multiple different P-wave morphologies, you're most likely looking at multifocal atrial tachycardia. And this arrhythmia is particularly common among patients having a COPD exacerbation. So you will see it among hospitalized COPD patients, and they will ask you about it on your boards. And the key thing to know about this arrhythmia is that it's generally benign. All you need to do is treat the underlying condition, meaning treat the COPD. There's no specific cardiac therapy indicated. These patients don't need digoxin or calcium channel blockers. They don't need anticoagulation. They just need treatment for their COPD exacerbation. And that concludes our video on treatment of COPD.